of discussing advanced directives with our residents on admission. And then as time goes by, each day the residents' status changes just a little bit, and those changes can be so subtle that we don't realize that there really is something different going on with this resident, and it might be time to revisit the idea of CPR, palliative care, hospitalization. So this form is really just a way of recording when that conversation occurs. And I think a lot of long-term care facilities, and I applaud them for this, will make this part of every resident care conference, and that's a great time to do this. You're reviewing the care plan. It's a good time to once again introduce the idea of what type of treatment the resident and his family or her family are choosing at this time, how aggressive this treatment should be, whether or not palliative care is appropriate, whether or not hospice care is appropriate. So the advanced care planning tracking form just makes a record of that can stay in the resident's chart. So you can see, oh, we haven't discussed advanced care planning or advanced directives with this resident in 3 months or in the past 6 months, and yet the resident's status and the resident's condition has changed profoundly. So it's really a simple form. You can only see half of it in this slide, but the rest of it is just a punch, whether we'll check boxes, whether or not the resident declined the conversation or participated, whether or not the resident chooses to be full code, DNR, DNI, artificial feeding, that type of thing. So the value in this, I would tell you, is that it just provides a record and a prompt as to the last time this discussion took place. Another good tool in this part of the Interact QI program is this patient/resident/family educational tool about deciding when to go to the hospital. And we hear, as we talk to our long-term care providers more and more that, a lot of these readmissions and trips to the hospital are driven by the resident's family. And I think in all honesty, we need to pause and think about that and reflect on that for a minute. If family members are saying, my uncle, my father would be better treated in the hospital, where did they get that idea? And did we provide a seed for that somewhere along the line? Are they sort of reacting to our concerns about our ability to treat residents in the facility? So I think when we talk about whether or not residents should be admitted or transferred to the hospital, the time to make that decision and have that conversation is not when the resident is on a stretcher on their way out, obviously. It's all through their stay at the facility. I would encourage you to take this patient-resident education form and share it with your staff and give it to your in-service person. Really think about having an in-service about this. And so in doing so, you can have your staff speak with one voice when it comes to hospitalization. And here's what they might say. What are the benefits of going to the hospital? Well, you have access to specialists, surgery if you need it, intensive care units. I think when residents and their families start thinking about surgery and intensive care units and that being a goal of hospitalization, they might have second thoughts. What are some of the risks? And these we know very, very well. Complications of care, worsening confusion, more time spent in bed, more time spent on the stretcher and the ED, less sleep, increased risk for infections. And I think family members are pretty savvy about this now with all the attention that MRSA and C. diff have received recently. Falls, infections, med errors, plenty of risks there. So again, we want to give a cohesive and coherent message about the benefits and risks of being hospitalized. And if we can kind of get our staff on board with this and speak with one voice, we can talk about this earlier in the change in resident condition. So when somebody's first beginning to need more treatment and visits from the APRN, that might be the time to say to a family member, listen, we prefer to treat people here whenever we can, unless we think they're going to need things like intensive care or, 3 times a day testing. We have the capacity here to treat people, and one of the reasons we choose to do so is that we're so well aware of the risks of hospitalization for our residents. So, again, I would really encourage you to share this particular tool with your staff so they can kind of speak in one voice to residents and families. So let's talk a little bit about palliative care, and that's something that's getting a lot of attention recently, especially here in Connecticut and our communities. So palliative care is defined as an approach that improves the quality of life of patients and their families based on the problems associated with life-threatening illnesses through the prevention and relief of suffering, early identification and technical assessment, treatment of pain and other problems, physical, spiritual, and psychosocial. Palliative care is designed to integrate the psychological and spiritual aspects of patient care, making care more holistic. Palliative care offers a support system to help patients live as actively as possible until death, offers a support system to help the family cope during the patient's illness and in their own bereavement, and uses a team approach to address the needs of patients and their families, including bereavement counseling as indicated. One of the things that appeals to us when we talk about palliative care is that it's a new term and a new paradigm. So residents and their families may be more willing to accept the idea of palliative care than they are to accept full hospice care. Palliative care is designed to provide an extra layer of support to people with chronic and debilitating illnesses. So when we talk to our residents about palliative care, we want to talk about how it will enhance the quality of life and positively influence the course of an illness. And I think this is a really important statement, and again, I would share this with your staff. Palliative care is applicable early in the course of an illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation. This is important because we've come to think of hospice as a real fork in the road and a turning point in someone's treatment. But once you go down the hospice road, you can't do things like chemotherapy and dialysis and other life-prolonging treatments. That's not what palliative care is about, and it's important that we send that message clearly. Again, here in Connecticut, we're blessed to have hospitals that have palliative care services that encourage us to make that referral, and that can be part of the conversation you have when a resident is hospitalized, and it can be part of what you put on your Interact transfer form that you think your resident would be a good person to be visited by a palliative care team. So stress that and think about that and share that amongst your staff. There's not a whole lot of people that we see in long-term care facilities who are not appropriate for palliative care. So if you feel like your staff needs a little bit more convincing, Interact also has a tool that helps staff identify who may be appropriate for hospice or palliative care comfort orders. And this, again, is an important teaching tool, I think, for families and for staff, because it can be confusing for family members, and I've had this experience my whole life, when residents first go to a nursing home and we're doing everything to keep them alive, and we're doing everything to get them better. And there's lots of hope that, they will go home and they will return to functioning, and then with each passing week, maybe that resident's condition changes a little bit, and slowly but surely it looks less and less like they're going to recover from this illness. So where is that fork in the road? And very often that fork in the road becomes an emergent situation when somebody's, presenting in the ED, and then all of a sudden, it's like, well, his DHF has progressed to the point that we're thinking that he might not have more than 3 or 4 months to live, and the family's stunned because it's the first time they've heard this. So, again, here's a good tool to share with your staff to let them know when it's time to start talking to families and residents about palliative care and comfort care. So you see simple things like CHF, got some blood values to use as parameters, ICU admissions for CHF usually, tell us that that illness is progressing. COPD, again, an ICU admission, deterioration in the ability to perform ADLs due to COPD symptoms, and dementia. And that's a big one. When in the course of dementia do we say that this person is nearing the end of their life with dementia? Because we know our folks with dementia can live quite a long time. So they talk about tube feeding, they talk about recurrent aspiration, and they talk about stalls. And of course there's no to that. So again, I would encourage you to share that with residents and share that with families and your staff. If you don't have your own comfort care order sets, and I think most long-term care facilities do a great job with this and do have order sets, but if you don't have them and you want to design some or you want to bump the ones you have up against some best practices, here's some interventions that the folks that interact have done to us. So we see diet becomes diet by preference, not by treatment. So folks are getting a more liberalized diet under comfort care or palliative care. Activity, again, by preference and tolerance. Less attention paid to vital signs. Avoiding IVs whenever possible because they're painful and cause bruising and are distressing and hard to maintain in frail elderly folks. And if IVs are used, if they're seen as having some value in treating an acute episode of dehydration, you want to limit the time that it's in there. Others for dyspnea and shortness of breath. Again, dyspnea really is uncomfortable and disconcerting to people as pain, so it needs to be treated aggressively. So these orders include things like steroids and the use of opioids and oxygen, and then hygiene, of course, avoiding any kind of Foley's and that type of thing, because nobody considers them comfortable. Okay, again, before I close out on this, I want to talk a little bit about the Advanced Care Planning Communication Guide that's part of this Interact Toolkit. And I'd really encourage you to open this up and share it with your staff development folks, share it with your staff. Kind of a step-by-step and scripted way of approaching this very delicate and difficult subject. I know some people despise scripted conversations or those kind of prompts, but you'll be surprised at how many people find them useful and are happy to have them. So in the communication guide, it talks about how to begin this discussion by setting the stage, choosing a private environment, allowing adequate time. Very often this is a conversation that somehow spontaneously happens in a hallway. So you want to make it a meeting. You want to make it a time where people can sit down and really concentrate on this big decision. Turning off cell phones and everyone sitting down. I know this sounds, kind of elementary, but I think that certainly in acute care you would be surprised at how seldom that actually happens, where everyone goes into a room and sits down, turns off the phone and talks about a treatment plan. Describing the purpose of the meeting, letting the resident and family know that you're here to talk about advanced care planning, advanced directives, treatment decisions to keep the resident comfortable versus very aggressive treatment. And most importantly, asking about their goals for care. Do the resident and family Are they more concerned with comfort than with life prolongation? If they're concerned with life prolongation, is there a specific goal around that? You know, sometimes you'll hear people say, I just want to see my grandson born. I want to live long enough to see my niece graduate from college. So eliciting that is really important. Using simple language and telling the truth about things like CPR and letting residents know that, yes, we can resuscitate you, but your chances of surviving resuscitation are less than 2%. You will get fractured ribs and probably a cracked sternum. Truth about tube feeding, that there's absolutely no evidence that they prolong life, that they really are of great benefit to people who are chronically and seriously ill. So let's give our residents the truth and give them the facts and let them know what evidence we have for these interventions and what they really look like. Another important message to send to residents and their families is that they do choose to not have CPR or not be intubated or not have a feeding tube, that doesn't alter the other types of care they receive. There still is a perception out there that once you're a DNR, you won't get aspirin. It's important that people know that there's many ways of going about this, and there's many choices to care, and the goal of all care really is comfort. You know, the opposite of comfort care is uncomfortable care, but we need to let people know what these things really look like and balancing the pros and cons and what evidence we have to support these decisions. And I think my experience in the long-term care facilities I've been visiting is that people do a really good job of this, and that the docs and the APRNs really can speak to this well. What we need to do now is to make sure that we're speaking to it and doing it on a regular basis, because when we do have this discussion, we're good at it. Okay, and of course, you know, to end the discussion, you want to ask people, do they have any questions? Do they have any concerns? Another part of the advanced care planning communication guide, as I said, is scripting, and some people think that's ridiculous, but some people find it very helpful. So I'd encourage you to share it with your staff. You know, what do you say when you don't know what to say? When somebody dies, when someone's had bad news. So there's something to kind of prompt from here. I'm impressed by how involved you've been with your aunt throughout her illness. I can tell how much you love her. I really appreciate your sharing your concerns. I know your hope her illness will improve. But are there other goals you'd like to focus on? Because we have, you know, a strong indication that she's not going to get better. And exploring concerns, of course. Tell me what you're afraid of. Tell me what's upsetting you. Opening up that discussion. So please do download the Advanced Care Planning Communication Guide and share it with the staff and get their feedback and see whether or not they find it helpful. So, in summary, advanced care planning is designed to help frame the conversation with patients and families. It should always be part of an iterative process and updated whenever there's a change. We need to provide continuous education to families and residents, especially about things like the risks and benefits of hospitalization. And these tools are designed to provide specificity. So we're not talking in general terms. We're talking to this resident, this family, about this condition at this time. Another thing that's suggested by the folks at Interact is if you're providing staff education about end-of-life discussions and some of these tools, you might think about doing some role-playing. If you have staff members who feel very uncomfortable approaching the subject, again, it's delicate, it's powerful. People have strong feelings about death, dying, how aggressive care can be. Some people might find the withdrawal of treatment sort of skirting next to euthanasia, and it's always, it's always enlightening to talk to people and ask them what they're really thinking, what they fear, what their religious beliefs tell them about end of life, how they want to die, what's their vision of that. Hope, in terms of a good death, what would that look like? Difficult subject to bring up, but important, as we know. Okay. Just briefly, we're going to talk a little bit about MOLST, POLST, and POLST. MOLST is taking hold. It's a medical order for life-sustaining treatment. POLST stands for Physician's Orders for Life-Sustaining Treatment, and it's really taking hold across this country. And the way it's different than an advanced directive is that it's an actual physician's order. So it arose from a concern that even though people might have advanced directives, they arrive at a new caregiver or a new level of care, and there's no physician's order how their and their wishes sort of slip through the cracks in the absence of an order. So it's a physician order that's recognized throughout the medical system. It becomes a portable document that transfers with the patient, kind of like a DNR, and it's usually brightly colored, and it's a standardized form for the state. It's different than the DNR is that very often it can have DNI information, other information about what a patient or resident wants versus what they don't want. So this program developed in Oregon in 1991, since has expanded to more than half of the U.S. states. Currently is an active program in Maine, Massachusetts, New Hampshire, and Vermont, where it's called POLST. The Progressive Vermont folks renamed it to Clinician Orders for Life-Sustaining Treatment. In the process of passing this legislature here in Connecticut. Forward, as you think about MOLST and POLST and wonder who would benefit from such a form or an order, it's anyone with a chronic and progressive illness, a serious health condition, the medically frail, and a tool for determination is to ask yourself if you wouldn't be surprised if this patient died within the next year. So again, this is another way of ensuring that our residents have their wishes met. I know that long-term care we try really hard to make that happen, but any time that a resident or patient transfers from one level of care to another, a lot of information can get lost, and certainly advanced directives, we've seen that more than once, might not be followed. But a medical order is a stronger statement and easier for the accepting provider to follow. All right, so I'm finished a little bit early, and I don't think anyone will mind getting 15 minutes back. But before we do that, I'm going to turn this over to Carol. Thank you for your attention.
Can we open up the line for any kind of questions that anyone may have for Sheila? If you have a question, please press *6 on your phone to unmute your line. Again, if you have a question, please press *6 to unmute your line.
Hello. Hi, this is Louise Flau from Covenant Health, and I guess it's sort of a question. I'm very familiar with the materials you went over, and I think you did a great presentation going through them. But I know that people are sometimes still confused between legally recognized so-called advanced directives under the Patient Self-Determination Act, which in most states just allows you to name a person to be a representative, and then the concept of advanced care planning. So I was kind of hoping that would be covered a little bit in the presentation, just to make sure that people understand that when we're talking to patients, residents, and families, in some cases we need to first establish whether they have this legal document about who it is that they would want to make the decisions for them.
Absolutely, that's a great point. Appointing a healthcare agent or healthcare proxy, but in addition to that, having that determination, something like a MOLST or an advanced directive from the facility, and I can speak to this from personal experience. I was the healthcare agent for my brother, who was very ill and spent the last year of his life in a nursing home, and that was good, and I felt like I could speak for him, and I felt privileged to be trusted with that. However, when he was transferred to a hospital in the middle of the night, I wasn't there, and I wasn't consulted about the next level of his treatment. So both things are necessary, both the healthcare agent, certainly to speak for the resident when they're found, when they're available, but also written directives of what the resident wants. And that's where I think, rolling out the MOLST system is going to be very, very helpful. Does that address your concern at all, or would you like to elaborate more?
No, that's fine. And I understand. I just, I sometimes find in talking to people, I work at a corporate office for a healthcare system, and we've got people actually on the call now from at least one of our nursing homes. And as I'm going around and talking to people, they sometimes forget that part of their advanced directive policy needs to sort of start with making sure that people have information about what's available legally in the state, the baseline, whether it's a proxy or a durable power of attorney for health care, and then maybe secondarily stuff like MOLST. And it all needs to be part of the conversation, I think. And Interact is one thing that Interact doesn't address in any of its tools.
No, it doesn't. That's a good point.
That's okay. We'll fill in between the lines.
But again, the more we as care providers can have this conversation, the more comfortable we get with talking to people about death, dying, treatment choices, the more specific the treatment plan will be, and the more we can refine what the resident wants. So that healthcare agent really does feel like they can speak for that person. The person with power of attorney really does feel that they know exactly what the resident would have wanted. But it's true, and that's, I think, another place, another gap that MOLST will fill is that you can have those folks and you can have advanced directives, but at that moment when a physician in an emergency department or an ICU has to make a decision, the more specific the guidelines can be, the better.
Thank you.
Great question. Thank you.
Any other questions for Sheila?
Yes, just one. Hi, Sheila. This is Sue from St. Patrick's Manor in Massachusetts. Hi. Thank you for your presentation. Excellent as usual. So we're very familiar with the MOLST, and also we heard POLST is usually out of New York. First I've seen was the terminology COAST. So we don't quite know where that one came from.
Vermont.
And COAST. So I'm just kind of curious.
Vermont is using COAST, which is clinician orders for life-sustaining
treatment.
Oh.
Okay.
You know how innovative they are up there.
Okay, now I understand then. Thank you.
Okay, so APRNs and PAs and other folks can do it.
Well, thank you so much, Sheila. Thank you, everyone. Morgan, did you want to Yeah, just before we jump off into our state-specific sharing, I did want to let you guys know that as you close out of the webinar today, you will be directed automatically to the evaluation for today's session. If you could please fill that out, we would greatly appreciate it. Obviously, if you don't have time today, or are sharing a computer with somebody else, you will be receiving a link to the evaluation tomorrow in a follow-up email, so you can fill it out at that time. The PowerPoint presentation is already on our website, but within the next few business days, we're also going to add the recording and transcript for today's webinar. The link to that will be found in the email that is sent out tomorrow. And then, I don't know if Carol's going to mention it, but our next Interact call is going to be on September 30th, covering acute change in condition. So I'm going to pass it back to Carol to talk about the state sharing call. Thank you, Morgan. So we're going to ask all the Connecticut participating nursing homes that are participating in the Interact Collaborative to stay on the line. We're going to give about 2 minutes for the New Hampshire nursing homes to jump off, and everyone else will be jumping off, Maine, Vermont, Massachusetts, and Rhode Island. But the New Hampshire folks, we have a special line for you to talk with Joyce Johnson, and that number is 1-888-309-6568, and the passcode to enter the conference line with Joyce is 861-864. So again, Connecticut participating nursing homes, please stay on the line. Everyone else, thank you so much for sharing your time with us today. This was a very important topic of the work that is done within the nursing home setting. And Sheila, again, you did a great job. Thank you so much. And we'll see everyone next month, same time, same that channel. But the Connecticut nursing homes, we're going to put you on mute for just a minute, and then we're going to start with our sharing session. So thank you so much. Good afternoon, everyone. This is Carol Dietz again, and this is going to be our sharing session. We usually have about 15 minutes to talk, but this time we have 20 minutes, and I think we're going to use all this time because this is an important time for us because we're rolling out the red envelope because we have a new acute care transfer process that's going to be starting on August 31st. And so we do want to talk about that today, and we're going to talk about the homework that we had last session, as well as homework that we're going to be giving you for this session. So with that being said, I was just going to hit the wrong button on the phone and turn you guys off. I apologize. All right, so the first thing I want to talk about, because we have been talking about this for the past 2 sessions, but I just want to make sure everybody is aware that we are going to have, the New England QIN-QIO, along with your community, will be having a Interact participation certificate available for those nursing homes that have met the minimum participation of our webinar series. So you have to have listened to at least 7 of the 10 sessions. We are in the 8th session today. So I'm going to be giving you the web link, the web address of how to access the other webinars if you have not listened to at least 7 of the 10 And also, along with this participation certificate, not only do you have to listen to 7 out of the 10 webinars, but you have to send Qualidine, us, the New England QIN-QIO, the Connecticut team, at least 3 months of readmission data. Now, what are we doing with this data? Nothing. But no, this is really serious, but what it tells us is that you have actually opened the tool, you are putting the data in, and we are hoping that you are using the data. That's the key. We want to verify that you are looking at your data. So by looking at your data, you have to submit the data. And it's part of the work that you're doing on a monthly, weekly, daily basis. So, many of the so we have 91 nursing homes that have signed the participation agreement. We have 44 nursing homes that have signed the data use agreement with us for achieving excellence, advancing excellence. Florence corrects me every month.
And by using advancing excellence, you will achieve excellence.
So, with that being said, Florence just received data from Advancing Excellence this week, and she was all excited. She goes, I can't wait to open up this data. And once we opened it up, we saw that 9 out of the 44 nursing homes that have signed the data use agreement actually have put data in. So in reality, that's 9 out of the 91 homes of the work that we're doing. So with that being said, and I do want to let you know, those 9 nursing homes, the average monthly submission was 5 months. So that's outstanding. We are giving you guys the high fives. If you were in the room, we'd be giving you high fives. So thank you for those 9 nursing homes. For those other nursing homes that are using Advancing Excellence, please start submitting your data.
And let me just pipe in, this is Florence. The importance of submitting data to Advancing Excellence is not a useless exercise. You will get more information by submitting on a monthly basis. You get to do a lot of benchmarking. Advancing Excellence sends you information about what your facility is doing, how the state is doing, how the nation is doing. And I think in the work that we do, you can't ever have too much data and have data coming from different angles for you to be able to evaluate how you're doing.
And as we have said time and time again, data drives your work. Data tells you where your gaps of care is. So that's why this data is so important. And that's why we're just asking for 3 months, but we are expecting you to continue to do this readmission tracking on a monthly basis. So with that being said, we are, starting next week, we are going to email individual nursing homes with this readmission tracking tool. We do not want your spreadsheets from the readmission tracking tool from Interact, because that has specific data, patient-level data that we do not want. You cannot send that through regular email. So this readmission tracking tool will take some of those data points that you have put in or that you can get at the end of the month, and you can just literally put it right into this tool. And I'm going to go through each of the columns so you have a better understanding of this tool. But I will say that with this email, with this tool embedded in the email, we will also have the information on how to fill this tool out. So with that first column, okay, so this is, the first column is the month of the year. So January, February, March, April, May. So this is for 2015. Also on top, you're going to write in your facility's name and the person who's completing the form. And if you could put your phone number, that would be outstanding also. Just so in case we have a question, we know who to call. So the first column, again, is the month of the year. Every month of the year. The second column is the total number of residents, which is the average daily census at the end of the month. And this, again, you can get from your business office about your average daily census. So
for each of the months. The next column, you're going to enter the total number of hospital readmissions within 30 days. So these are the unplanned hospitalizations from the entire facility. So we're not asking you to break it down. We are asking for the entire facility. And these are the patients that are admitted to the hospital on an inpatient status. These are not ED visits. They are not observation status patients. These are inpatient status. And we do not want any of the planned admissions included into this count. An example of a planned admission are a scheduled non-emergency surgical procedure or patients going in for a blood transfusion, a planned blood transfusion, or for planned chemotherapy. So those are just examples of planned admissions. They are not part of the count, only unplanned hospitalizations. The next column, which is the total number of transfers to the emergency department within 30 days. These are all-cause ER transfers, emergency department transfers, and then are sent back. So they are not inpatient, they are not turned into inpatients, because that would go into your inpatient column. Now, just to give you, and I did not know this, but this is an Interact statement that a resident who dies in the ambulance or in the emergency department should be put into this column, the emergency department column, okay? So I just wanted to make sure you're aware of that. Both Florence and Sheila are shaking their head, yes, they knew that. Okay, so I'm the dummy, okay. All right, that was one of those aha moments. Okay, the next column is total number of transfers that were observation status patients. So again, they're stayed in the hospital for about 2 or 3 days, but they were not in an inpatient status, they were observation patients. And the very last column, this calculation is your readmission rate. This calculates itself. So as you put in your average daily census in that second column and your total number of hospital readmissions within 30 days, in this column, the calculation for your 30-day readmission rate will occur. So you do not have to do your calculation. Okay? Good. So Florence just asked a really good question. That's why she put you on hold, because she wasn't sure. This does not take place of the Advancing Excellence. It does not replace Advancing Excellence data form. But for those nursing homes that have not signed a data use agreement or are not putting data into Advancing Excellence, this is the form we're asking you to use to submit at least 3 months worth of data to Qualidigm. Okay, does that clarify? So one last thing about this tracking tool. The earliest you can input readmission rates for a given month is 30 days after the end of the month, because the resident who was admitted to your facility on the last day of the month is at risk for a 30-day readmission for 30-day period following the admission. So again, this is a very simple readmission tracking tool. We're not trying to replace it with the Interact tracking tool, but this is how we would like you to get your data to us. And at the end, we're going to have questions. So right now, we still have everybody on hold. On mute, but we will have questions at the end. So as I mentioned earlier, this is if you need to watch some of the previous webinars, you have to get onto the New England QIN-QIO website, and this is the web link. And then once you're on the landing page, you're going to click on events. You're going to scroll down a little bit. You're going to see previous events link. You're going to click on that. And then you're going to click on the previous webinar recording that you need to listen to. And right before you get into the webinar, a screen's going to pop up, asking for your name, asking for your facility, because we are tracking everyone who is using these webinars, so then again we can track on who is participating. So we do this on a monthly basis.
But if you prefer, as you're completing watching the webinars, you can even email one of us to just let us know that you've done it. That's fine.
Thank you, Fawn. Okay. Let's talk about some new news from DPH. Now, we have been doing the happy dance here at Palliative for the past 3 days because of this last fax that came out on Friday. And basically it says it's all about the data elements that have to be transferred with the patient for an acute care transfer from the nursing home to the hospital. And so they have heard it, DPH has heard us that we needed this last fax to come from them. So if you do have any questions about this, we can talk about this once we open up the phone lines. But again, this did come out on Friday. It is because of our request from them for the past 2.5, 3 years about how the transfer form plus the face sheet fulfills all the data element requirements from the Public Health Code. And again, you have to fill out that transfer form completely, that first page of the transfer form, along with the face sheet to fulfill those requirements. So, moving on. Let's talk about the homework from last session. We did have a lot of homework. One of the community meetings, it was the New Haven community meeting, the community leader said, boy, this was a lot of homework, but we wanted to make sure that you were putting the right processes in place for this new acute care transfer process. And that's why we were very specific about looking where are your copiers? Do you have enough of them? When you do have an acute care transfer out of your building, is it a one-man show, or do you bring your team in? You need to have a team help that nurse transfer that patient, transfer that resident to the ambulance and then to the hospital. So that's what all the homework was about. So we first started out with making sure that the team leader downloaded the right forms, that the team leader actually downloaded it to the server, so you have the forms available, that the team leader is going to talk to the vendor to make sure you have red envelopes in your building. You're going to look at where your copiers are located, and you're going to have 2 team meetings this past month to make sure all this work is being done. So during your first team meeting, you're going to review all the Interact tools. You're going to discuss how your staff was going to get trained on these tools, and making sure you talk to your leadership and your medical director. You're also going to make recommendations to your leadership if you needed extra copiers or if needed to move the copiers to make sure that when that acute care transfer is being taken place, that making that second copy for EMS is going to be easy for your staff. And you're also going to verify that the red envelopes have been purchased, and also that you're going to put a team together to put those packets together, because again, you don't want to be stapling the transfer form or the transfer checklist to the red envelope as you're calling 911. And finally, that second team meeting, you're first going to map out your current status on how, when an acute care transfer takes place, what actually occurs, who does the work, and then you're going to map out the new acute care transfer process using the new tools, putting a team in place at any time, whether it's day, night, or day, evening, or night shift, that everyone knows that they have a job to do, and it's not a one-man show anymore. And also, you're going to talk about which unit's going to be using the new acute care transfer process first, and then you're going to debrief about it. With that being said, let's have a discussion. Morgan, can we open up the line? Unmute everyone, please. And so let's talk about your lessons learned, your barriers.
All callers are muted. All callers are unmuted.
Okay, do you have us on hold, please? So,
All callers are muted and may unmute themselves by pressing *6.
So if you have a comment, please press *6 to unmute your line. Since you had somebody put us on hold, we can't unmute everyone. So if you want to talk to the group, please press *6.
Hi, this is Lori from Vernon Manor.
Hi, Lori from Vernon Manor.
Hi. I have a question about the readmission tracking tool. If we're doing the Advancing Excellence, do we still have to do the readmission tracking tool?
No, but Vernon Manor was not one of the nursing homes that has put data into Advancing Excellence as of this last data submission.
Oh, Christy has been putting it in, so I'm going to have to check on that.
Vernon Manor, do you go by another name?
It could be under Arbors at Hopbrook.
No.
Oh, because
Yeah,
she's been in for a few months now.
Okay. Well, why don't you Florence will follow up with you, Lori, okay?
All right, thank you.
Thank you. That's a good question.
Hi, am I
All right,
coming through?
Yes. Yes, you are.
Hi, it's Bridget over at Portland here. How are you?
Good. Hi, Bridget.
Hi. We've been putting data in, and I have a feeling that it's not being entered to you because we're not getting any feedback. Human Resources, Melinda, did meet with the group. She's trying to get a hold of someone to see if maybe we need another in-service here. Do you know if it's coming through?
The 9 hospitals that we have gotten, out of the 9 nursing homes that we have received data from, Portland Manor is not one of them.
Okay. So we're doing
Bridget, it's
something
Sheila.
wrong.
You know what? I have Melinda on my to-do list to call, and I will call her.
Okay,
And,
great.
stick around there. So, yeah, I would love to see you guys register for Advancing Excellence. You find a lot of good stuff on there.
Yeah,
In addition to the tracking tool.
Another comment, did you ever see or find out about the notice of transfer and discharge to go into the packet?
Yeah, I remember you talking about that, Bridget. I haven't heard about that from DPH. I'm interested, do all facilities do that? The notice of discharge? This is like the state process by which a bed is held or a resident is informed about how long the bed needs to be held, yeah.
Correct.
I don't
Reservation
think that's a requirement, no. Together with the resident, I haven't heard that.
Right, it has to go with the W-10, and then it has to be mailed to the responsible person.
No, I haven't heard about that being part of the acute transfer process.
Okay. One more, I'm sorry, while I have you, can I ask one more question?
Absolutely.
Is there any way that we could get that transfer form into Word so that the demographics can be done neatly on the computer? You know what I mean? Because right now we're actually typing all the W-10s with all that information in blocks on the W-10, but it's all on the computer, and then only handwritten is the reason for transfer, so legibility is much improved. So I'm wondering if that form can be put on so that we could actually put all the demographics, the history, the stuff that's not going to change on those, so when the nurse fills it out in a 911, she only has to fill in the most, immediate information.
I believe, and this is Florence speaking, I believe if you go onto the website and you actually download the form, you can then type in it on your computer.
It's not allowing me.
Okay. We'll get your contact information. We can walk through it. Yeah.
Okay, great.
Okay.
Okay, thank you.
Okay, go right ahead. I was just going to jump in on the transfer form. You actually have to click on an icon when to open up the form in order to edit it. I don't know what the icon is called, but it kind of looks like a little pencil on a piece of paper. So once you click on that, you're able to edit the form.
Excellent.
Thank you for that.
Thank you. That is a best practice, I think.
I just wanted to mention about the Advancing Excellence tool. I think there might be a misunderstanding. When you enter the information on there, it's not automatically transferred, and that's actually where I need help myself. I don't know where to go on the Advancing website to actually enter the data to submit it to you guys. I think that might be part of the...
That's actually a good point. Thank you for bringing that up, because I have spoken to people that assume that because you're working on the Advanced and Excellence tracking tool that it automatically dumps the data. But no, you need to go onto the Advanced and Excellence website and click on Submit Data. And this is where you need your username and password, because you cannot work in the data field without your username and password. And maybe we need to do a segment where we walk people through that.
Okay. Next month?
Yeah.
Okay.
Thank you.
So next month we will add this to a 10-minute walkthrough of Advancing Excellence, so everyone can see how to submit the data. So we can pull the. So then we, Palliative, who has your DUA, can then pull your data, so you don't have to fill out that other readmission tracking tool. Thank you. Thanks for that recommendation. Now, I have some lessons learned. I want everyone to... I will ask that in a minute. I just want to make sure we have these lessons learned. Since I've been going out teaching to the EMS as well as to the emergency departments about the red envelope. Again, we're rolling it out as of August 31st. Next Monday, the hospitals are going to be... The hospitals within the 3 communities, so there's 13 hospitals. So the other hospitals, if you transfer to other hospitals that are not part of the Hartford community, the New Haven community, or Middletown, you need to make sure that you make that phone call and talk to the emergency room director to let them know that you are using the red envelope, which will not have a W-10 in there. And this is a lesson learned. Make sure the phone numbers on the transfer form and on your capabilities list actually goes to a live person. And that because there are going to be phone calls, there's going to be nurses out there and physicians out there that have not heard of the red envelope. We're trying. We're getting out there. But they're going to be looking for the W-10. They're going to call that number that's on that. So make sure that number is that phone number is to a live person. With that being said, whoever takes the call should be scripted on, we are part of the Interact Collaborative, we have been working with DPH and Qualidine, we are using the transfer form and the face sheet to replace that W-10, and it's all about data elements, so you need to have that script. So at 2 o'clock in the morning when that nurse calls looking for the W-10, it's not a heated discussion, it's not, you're just saying these are the facts. And so please have that done before Monday. And also make sure your capabilities list is up to date, and you already have that in the red envelope. You're going to be having the advanced making sure you have all the forms available as you do an acute care transfer for that first time. Having that team in place, even having a practice walkthrough on the 30th with your day shift, your evening shift, your night shift team to make sure it's all in place so no one's running around. And having that second copy made for EMS is really important because they need that information to continue on with their care. With that being said, Florence wants me to ask one more time, are there any other questions about the fax blast, about the readmission tracking tool that we're going to be sending out? And *6 to unmute your phone, since somebody had us on hold. Okay, so here's the homework for next Hi, go ahead.
Hi, this is the Marcus from Leeway. How are you?
Fine, thank you.
I'm afraid I'm gonna have to get off the call right now because it's getting really busy here where I am.
Okay. Thank you.
But thank you so much for the information, and I'm definitely gonna get started on those things that we discussed.
Excellent. Excellent. I understand Sheila has been in communication with you, so excellent. Thank you very much.
Yes, thank you so much. Have a great day.
Thank you, you too. Here's your homework for next month. Again, we want you to download the Advanced Care Planning Tools and Communication Guide, and we want the team leader to make sure that it's somewhere on your shared drive at your facility. And then, just like we always do, we want to make sure that the team reviews the tools together before they spread the work. Then we want you to have a plan on how you're going to be teaching your staff, nurses, your social workers, your supervisors, your leadership, and your medical directors on these tools. You develop a timeline, and part of that education and debrief, you want to make sure as soon as you use one of the tools, you always debrief after it. How did it go? What could we have done better before you start spreading the work? And please remember, data should be part of your everyday work. Your readmission tracking tool needs to be updated daily, so you've got to make sure you touch base with the staff member who is putting that data in. Are they having any issues? And if so, give us a call. So thank you so much. It was a great session. I know we're 9 minutes over. That's my fault. But we'll see you next month. And please know any one of us are just a phone call away. Please don't hesitate to call us. That's what we're here for. So thank you so much, everyone, and we'll see you next month. See ya.